If you just give us 1 second, we're going to present the case first. Dr.
Sure.
Abrar, can start.
Sure.
You can start it.
Gary, is there enough water? Because he cannot immerse enough water.
Thank you. A 54-year-old gentleman,
Check the
medically
pump,
free,
is it?
status post-cholecystectomy long time ago, post-ERCP with single segmental common hepatic duct structure. Today, planned for ERCP and cholangioscopy with spy bites.
Okay, thank you, Abrar. So if we can switch back to the room, please. Yes, Dr. Imad,
Hello,
Dr. Saad.
everyone. How are you? So, thank you so much for streaming into our room. So, as explained in the presentation or the slide, that this patient has been having a biliary stricture located at the junction between the common bile duct and the common hepatic duct. Apparently, one of the challenges that we are facing are indeterminate strictures, meaning that we don't know exactly the pathology behind the cause of the stricture. So here where cholangioscopy comes to play a major role in determining the possible features could be seen to help diagnosing either this is favoring benign or favoring malignant stricture. And then comes the advantages of having a cholangioscope to offer a direct tissue biopsy. That means tissue biopsies under visualization, or at least do some interventions included in that matter. So Saad now is actually, we have removed the plastic stent previously placed. We actually introduced the cholangioscope inside the common bile duct. We are actually up to the common hepatic duct, seeing the bifurcation. And now Saad is going to withdraw the scope slightly to see if we could appreciate the stricture and the features that could help us identify the underlying cause. So
as you can you guys hear me?
Yes, we do.
Yeah. So actually, we did the standard ERCP first. There were 2 plastic stents that were removed, and actually, then we did a cholangiogram, and there was a very short stricture at the common hepatic duct. And what's interesting enough, Dr. Imad pointed out that it's right next to the cholecystostomy clips on fluoroscopy. I don't know if you guys can see the fluor or not. But we're examining the bile duct, and Dr. Imad, can you identify any stricture here or any abnormalities?
So, you know, one of the major things we have to look at is the mucosal changes before you decide if what kind of stricture. So the mucosa usually, if you would appreciate what I'm seeing right now, there's a hypervascularity in the area. There's irregular service covering most of the, like more than 50% of the lumen of the bile duct. This is all abnormal. If Saad, could you push the scope more proximal, higher, you would see that those changes disappear and you would have a much healthy appearing duct with normal mucosa. So irregularity by itself, increased vascularity, easy to bleed, different stricture types and kinds, these are all indicator that there's something abnormal. So at the bifurcation, the duct looks unremarkable. Then you would see some lobular changes. If you could go up, all the way up to the right hepatic, looking down. So what you see now is basically the normal duct. That's how the normal duct looks. It's not that different from seeing a colon, for instance, when you do colonoscopy. This granulation tissue you could see there, you keep in mind that could happen when you place a plastic stent. Reactive tissue, inflammatory reactive tissue, very focal, but that doesn't mean if you suspect anything abnormal, you just take biopsies using the biopsy forceps. And we're going to go back and focus on the stricture of interest,
so
which was
do you think
located...
this is a benign or malignant stricture?
The one I see right now?
Yeah.
Dr. Ahmed.
Yes.
This is Ibrahim Mustafa. My question for the audience, it is normally to use a spyglass in a case like that. If you have a case like that, you use a spyglass or you remove the metallic stent and you put plastic stent if it's something in the mid-common bile duct, because spyglass is very expensive. So in a case like that, you use it. It's
absolutely.
benign.
So, yeah, I'm sorry. So basically, the best approach to this, you may choose not to use the spyglass in the index ERCP procedure. Especially if you have, let's say, straightforward gallstones or straightforward pancreatic, let's say, stricture, malignant stricture. When you actually understand or know as for a fact that this stricture or that narrowing or obstruction is caused by an well-known pathology. However, there is a subclass of lesions within the common bile duct or biliary tree, which we call indeterminate stricture. These have gone one ERCP, they did brushings, maybe they did biopsies, and none of that showed anything conclusive. And therefore, we may need to do the next ERCP with more tools to help us diagnose this. These tools considered are the spyglass or the cholangioscope. Cholangioscope, if you suspect that kind of lesion, I myself prefer to go with the index ERCP spyglass, because the more you intervene, the more you place stents, especially if they were plastic or metallic, that can create a compression damage, trauma to the tissue, and therefore, when you take biopsies from the lesion, they can be only showing atypical cells, which cannot diagnose the patient.
So,
but
Ahmad,
since we have that case,
yeah,
right now, yes.
So I would agree. I mean, just in case, probably he's like 58 or 60 years old, and his cholecystectomy was like 25 years ago. So, I mean, sometimes you wouldn't like to miss any malignancy. But for now, back to Dr. Abid, question, the stricture here, do you guys think it's more with malignant or benign? Because I see some blood there. Maybe it's a little bit obscure the view for us, but I don't know if you have a better view before.
So Saad now is trying to get us a good view to help identify some of the features that would favor benign or malignant. So right now we are dealing with bubbles. This is best conducted when you have water immersion. You could see everything underwater much better than just having those bubbles roaming around. So if we could just, yes, there we go. So a little section maybe, let me just help you with this.
So also we have to keep in mind as well is patient intubation, because this patient is not intubated. So I'm trying to kind of be conscious about that.
Okay.
Yeah, I think now we can see that it's more like, I don't know if you guys all agree, it's more like an inflammatory at the meantime here, maybe with the effect of the stent. And there is a question, Dr. Hamad.
Yes.
Okay, so if I mention something here really quick. So the types of cholangiocarcinoma, they would appreciate, it's either papillary, or if you can see nodular type, or if you could see infiltrative type, sorry. So basically, this is kind of much more granular, overgrowth looking appearance, much more kind of favoring reactive tissue rather than seeing a real new vascularization or papillary infiltration. Or I see also that the lesion itself, as you could see, it's not actually circumferential. It's on one side of the duct. That's not usually what we see commonly in cholangiocarcinoma. However, another thing to add to the fact that lesion, or what I mean the stricture, is located exactly at the level of the cholecystectomy site, the clip, I mean. If we could refer back to the fluoroscopy image side, if we could just fluoro, yes.
So until we
You
get
could see
the
that we are not-
fluoroscopy, Ahmad, if we can just have a question from the audience.
Of course.
Ahmad, Saad, the question is, this man had cholecystectomy a few years ago, and someone did ERCP and he put a plastic stent, assuming that this is post-traumatic stricture, most probably. And the man is still alive. And when you remove the plastic stent, I can see a duct. And I can see the common hepatic, the right and left hepatic duct. So for my thinking is this, as you said, there is no stricture. It is just inflammatory, post-inflammatory. And now the man is alive, and there is no lymph node, and there is no complication. CA19-9, it was high before, or?
I'm not sure.
Do you have any idea? When was the lab coli?
So he was just recently found to have a stricture. Nobody know when was the stricture started.
Okay, the
So,
plastic
and his
stent.
cholecystectomy was 25 years ago.
No, but the plastic stent was
Oh,
when?
just like few weeks ago.
The problem that, Sam, the problem that, as you said, the cholecystectomy is very old. So if he did the cholecystectomy 30 years, and then he had structure now, so Ahmad and all the people, he is right to do an spyglass. Against what I said in the beginning. So the problem that he has cholecystectomy, very old, 30 years, and they get structure now. So who bought the plastic stent? They should from the start doing spyglass and so I agree with what they do, Ahmad and his colleagues, that this case especially need from the beginning good assessment to it's a benign or malignant.
And it's actually another point is when to do the spyglass. Do you do it in the index procedure or no? I mean, maybe because in most probably of most of the centers, the endoscopy is done under conscious sedation. So what we used to do is when the patients first come under conscious, we do a brush, but we bring the patient within the next 2 weeks under general anesthesia for spy bites if the brush is negative. However, if you have deep sedation from the beginning, I would agree just to do the spyglass from the beginning. So that's probably what was done for the patient and the reason for just the stent without spyglass at the index procedure.
So, Ahmad,
thank you all for the comments. Another point that I want to talk about what Dr. Adel alluded to. So we have cost effectiveness data. I was lucky to publish about the cost effectiveness of data of SPY in the index procedure for stones, which is a different ballgame. But however, it showed that patients who come from outside of the city, who don't have access to spyglass or referrals, and they come to a referral center, for stones, it showed that there is a definite cost effectiveness to go ahead with SPY, assuming that the patient underwent all the proper therapy for like lithotripsy, I meant for like balloon extraction, sphincteroplasty, and all that. For strictures, we are also like this patient, if we don't do the SPY for him, this is not going to happen for a while. He's going to go home. He's traveled all the way for this procedure close. There's flight expenses. There's like social life expenses. So there's a lot of expenses. And we've gone through all this trouble of putting the spyglass inside this man's duct. And that's why I'm actually going ahead and biopsying. In addition to the story that he's actually in his late 50s. Yes, son. He's in his late 50s. The cholecystectomy is a long time ago. So I don't want to fall into the trap of like premature closure and just brushing it off by saying it's probably post-cholecystectomy, which can definitely be. But I just want to do my due diligence since I'm here in the duct and just take a biopsy.
And you know, one thing also, Saad, is like, really, he deserves, like, I completely agree with your point. Like, if it's like a stone, this is a completely different game. You could try one, twice, thrice, ERCPs trying to clear before he may think about sending the patient down the road to a center where they have the spyglass, or even yourself to use a spyglass. However, if we are dealing with strictures, time is an essence. It's like great essence here, because if you miss that stricture at earlier stage, where you can actually do something about it, especially if you can refer the patient to surgery and have resection, curative resection, you are dealing with a very limited choices after that when the disease is advanced. So I can completely justify jumping on the stage and putting a spyglass to take biopsies and determine if this is malignant or not. Spyglass or cholangioscope can help in two different ways. Number one, the way it looks. Number two, by tissue acquisition that can be helpful in increasing the diagnostic yield.
So Saad, Ahmad, when you have a stricture, do you do the three things, or you just do biopsy from the? Do you do brushing, some bile for cytology, and you do biopsy, or you just go for biopsy only of abnormal? The yield of 3 is better than the yield of 1?
Yeah, it's a good question. Yeah. I remember I spoke to one of my mentors earlier on. He says, we keep talking about how many times passes we do on EUS FMB, but no one ever talks about how many brushes we take. Even though the brushes are not that expensive, but we all know that from data, brushes diagnostic yield is around 35%.
Right.
So it's not that great, especially in the era of EUS. However, as Dr. Adel said, if the patient comes for a conscious procedure, the wire is right there, we try to take at least a couple of brushes, and then we depending on the structural location, we decide on the next procedure, whether we go directly to SPY or EUS. If it's a distal stricture, sorry, take that, yeah.
So we have a question from
then
the audience, Dr. Mu'tasim.
Saad and Ahmad, great job. First of all, for the how many bytes in the SPY bite
We can't hear you guys.
Hello, do you hear me?
The
Thank
question
you.
is how many
Sorry,
bytes
no,
you would take to roll out.
No, do you hear me, Ahmad?
Yeah.
And
Can you,
Saad?
So, yeah.
Yeah, so
Yeah,
I'm not, that's not my question. I'm just answering the questions. Byte, it's more than 6. They studies now, they said more than 6. The thing is, if this patient presents with pre-exist stone in the CBD and he has a stricture, that's usually easy to say that's inflammatory. With the study we are conducting with 25 stricture, I'm done. Unfortunately, if you don't have a stone in the CBD before you have a stricture or like Merisi syndrome, the most likely this is going to be ended by cancer. Unfortunately, we know that cholangiocarcinoma, it's indolent and subepithelial. So usually when you see a stricture in the CBD, like this patient, he has a mid-CBD stricture, that's the best patient to send to the surgery because it's only hepatogenostomy. He's not in the distal or for missed. So my question for you, if you have seen any stone before, and the second thing for this patient, if he has no cancer by biopsy, he eventually will go for surgery. We know the inflammatory stricture, usually they go to surgery at the end. The difference is if it's a cancer, it has to go to neoadjuvant or thing. So have you seen any stone to start with or before? The second thing, from also your experience, those patients usually go to the surgery, proving the cancer, it's just for not neoadjuvant, adjuvant, because they did the neoadjuvant for cholangio.
Well, we couldn't hear the question if there was any question directed to us. So if the panel could help us just...
Was there
so
any...
what was the question?
Yeah, no, was there any stones in the history that could explain the stricture other than the history of remote cholecystectomy?
Well, you know, yeah, that's a great question. Whether it's the chicken or the egg, I totally understand the point of, you know, there can be different reasons for the formation of a stricture. The spectrum starts from the benign, to the most benign to the most malignant. However, just, you know, we can speculate. We can be very skeptical about like what could be the cause of this stricture. Could it be the clinical scenario of having cholecystectomy in the past? Could it be a stone that passed and formed a stricture? Could be a focal cholangitis or severe cholangitis that have resulted in such complication leading to such a problem, or a impacted stone, or you could just go on the reasons for this formation. But you know what, when it comes to, if you want to have a fact, what's standing behind this, seeing is believing. You must go and shed the light on that location, see what could it be possibly related to, take biopsies if indicated, and that you can cut the whole thing short to the point like, listen, I had multiple cases coming to me, like one of them was basically post-cholecystectomy cirrhotic patient with a stricture after 7 to 10 years from cholecystectomy, and there was a cholangiocarcinoma on top of the list. I did the ERCP as an index procedure, and you know what? We called it off on the first session. We said, this is post-cholecystectomy stricture, and there is nothing more to be done about it. So I agree, it could be anything. Collecting and obtaining a good history is very important because that would favor one thing over the other. But when it comes to diagnosis, we need to do something.
Okay, so thank you very much, Ahmad and Saad.
Yeah.
So we'll just...
ERCP. So the biodegradable stents basically is one of the options that we can consider for those self-dissolving stents that can be applied or introduced to either biliary strictures, or you can have stones or any pancreatic strictures. So the feature about this stent is basically you can just place them and forget about them as they completely dissolve in a matter of weeks. So we have, available in the market, we have 3 types of stents of Archimedes. We have, of course, the pancreatic, we have the biliary. They have the slow, biodegradable, the intermediate, and the fast. The slow can just dissolve completely in a matter of 12 days. The intermediate can last for 3 weeks, and the slow type can last for about 3 months.
So, Imad, this is uncovered stent, right? It's a biodegradable
they are
uncovered.
plastic stent. They are plastic
Okay,
stents. So
plastic,
yes.
perfect, good.
So
That's an advantage that you can place it at the bifurcation.
Place it as what?
Yeah, at the hilum, so it will not obstruct one of the ducts. It's not like the metallic, so that's the advantage of plastic.
Yeah, I mean, you can definitely consider them for that. I myself would try them in case if you had difficult cannulation and you ended up actually putting a pancreatic stent. I would rather put the Archimedes, the short or fast dissolving, which can just disappear in 10 days. We have to bring those patients back in order to make sure the pancreatic stent has fallen off, otherwise it can lead to pancreatitis. So this is another solution to minimize the need to repeat the procedure in case if you have difficulties with slots and time.
And what's the expected time? Sorry, go ahead, Prof. Ibrahim. No, please.
What is the size of these stents, the diameters?
The size of
the diameter of the stent.
So they come in different sizes. They have the large spectrum of portfolio in different sizes. Of course, when you talk about pancreatic stents, you're talking about the 5 French. They may range from 4 to 5 centimeters. When you talk about the biliary stents, they can be like 7 French or larger.
No, about the biliary stent, about the common biliary stent. If you put a stent in the common bile duct, what is the size? It's 10 millimeters or?
I would ideally put something like 7 to 10 French for the bile duct. Yes.
So this one you have now, how many French is?
No, the stent we have now is just a regular plastic stent, non-dissolving or non-biodegradable. So this is the plastic stent. For the sake of patients' preference, the team at King Fahd Medical City preferred to place a plastic stent. They did not want to go with a biodegradable for their own reasons. But it's always also an option available in case that they are interested in that.
And what's the expected time for the biodegradable to dissolve?
So as I mentioned, they come in 3 different types. They have the fast, the intermediate, and the slow. The fast can dissolve in a matter of 10 days. The intermediate, they take about 3 weeks to completely disappear. And slow, they take up to 3 months.
So I think just for the audience, probably the fast one, the 10 days, it's actually perfect for post-ERCP pancreatitis prevention.
Absolutely.
So you just need to put it for 10 days and then it will dissolve instead of bringing the patients back and taking the pancreatic stent out.
Absolutely. And you know what? In case if you're treating like a chronic stricture or difficult stricture, you may choose to